Okay. All right. I'd like to welcome everybody to our Wednesday Lunch and Learn series. Today, we're going to be talking about vaccines and Medicare. And we have with us Michael Ybarra from Pharma, and he is going to share a little bit of information with us. So with that, I would like to welcome Dr. Ybarra.
Thanks. Thanks, Arlene. Thanks for having me. Can everyone hear me okay? Okay, good. Thanks. Well, it's nice to be with you. My name's Mike Ibarra. I'm an ER doctor. I did my medical school and residency training here in Washington, D.C. I'm actually in my office, though, at Pharma, where I'm the chief medical officer. And you're really excited to talk to you about vaccines. It's a small group, so please, raise your hand if you have any questions that I can help answer while we're here. Otherwise, wanted to just go through a little bit of content. Today's Lunch and Learn is about vaccines and the critical role that vaccines play in protecting the health and independence of older adults. It's really a privilege to be here with you because I think and I hope that we all share the commitment to advancing evidence-based care for seniors. And as you all know, older adults face higher risk of serious illness from vaccine preventable illnesses like shingles, influenza, pneumococcal disease, RSV, COVID-19. And at the same time, there might be barriers that your community faces to vaccination, from access challenges, misinformation, to really complex reimbursement systems and coverage systems. So hopefully over the course of the next few minutes, we can try to unpack both the science, but then also the systems for how vaccines work, what's new, what's emerging, and how we can better ensure that patients receive the protection that they deserve. Does that work for everyone? All right,
Yes.
great. Well, we've seen a lot of progress in terms of vaccine preventable illnesses, new vaccine platforms, improved formulations, things that are tailored for older immune systems. And these advances represent decades of research and ongoing safety monitoring systems, a testament really to what we're able to accomplish in terms of prevention. Um, we really need trusted sources of information for everyone, but in particular for older adults when it comes to vaccination. And the conversations that we have in clinics, at senior centers, in the ER and community settings can really make a difference for whether someone's going to choose to get protected or not. So hopefully we can empower those conversations with facts and actionable strategies. And what you see here is really the dramatic decline in cases of diseases that you probably have heard of. Has anyone seen any of these diseases? Diphtheria, smallpox, measles, mumps, rubella, polio, tetanus? Have any of you seen any of those diseases? So I see head nodding, but what's so interesting is, I went to medical school I graduated about 20 years ago, almost 20 years ago, and I've never seen these diseases. And that's because of vaccines. And that's because of the power that those vaccines have when they're used and deployed appropriately to really, protect communities, protect individuals. So you have a variety of vaccines that have done a lot to reduce the burden of illnesses in communities. And what this slide shows, it really tries to capture the bigger picture of vaccination, not just as a public health success, but really as an economic and societal success as well. First, if you look at some of the top line information, since 1974, more than 154 million deaths have been averted globally because of vaccines. That's not just data, that's really generations of lives extended, families intact, communities protected. And in the US, childhood vaccines alone have saved $2.2 trillion in societal costs. That's because kids are kept out of the hospital, parents are missing less work, and less long-term disability. The COVID-19 experience really is another powerful example. In just the first 2 years of the pandemic, with vaccine rollout, we were able to prevent 18 million people from being hospitalized and save nearly 3 million lives, resulting in over $1 trillion in medical cost savings. And if you ever need an explanation for the value proposition of vaccination in just one line, I think the bottom stat really captures it. Adult immunization programs can return up to 19 times what is spent, generating about $4,600 in benefits for every adult who completes the vaccination schedule. So, in other words, vaccines are not just life saving, they're one of the smartest investments in public health that we can make. And I think beyond all of these stats is just a really powerful visual example. I think, if you went to a cemetery and you looked at the tombstones from 100 years ago, you would see that it is filled with many more children than there are today. And that's because of vaccines. Vaccines are able to prevent early death for a number of childhood illnesses, and that is an incredible gain. This slide is a good reminder that not all vaccines work in exactly the same way. Their purpose and the type of protection is going to depend on the disease that you're trying to treat or prevent. So, what you see on the right are a set of vaccines that are really designed to prevent diseases from being spread from person to person. And a really good example of that is the measles vaccine. These vaccines target viruses or bacteria that don't change very much over time, so the immune system can easily recognize and stop them before they spread. Below that, in the bottom right, you can see examples of some vaccines like the COVID vaccine or the flu vaccine that really focus on preventing severe disease rather than completely blocking infection. These target pathogens that are evolving frequently, so changing quite a bit. We know that every year a different strain of flu tends to circulate, just like a different subtype of the COVID virus circulates. So we have to update the vaccines to match those circulating strains. And then what you see on the left is really exciting because we now have therapeutic vaccines, which are a newer frontier. So instead of preventing an infection, these vaccines are actually designed to help the immune system fight a disease the person already has, like cancer. We see mRNA vaccines being studied to treat cancer. So I think the key takeaway here is that vaccine design is really tailored to the biologic threat that we're going after. And even though the types of protections might differ, each is going to play a vital role in improving health and saving lives. This slide illustrates one of the most powerful and I think sometimes overlooked benefits of vaccination, and that's community protection, or what we sometimes might call herd immunity. So what you see on the left is what happens when too few people in a community are vaccinated. The infection spreads easily from person to person, including to those who can't be vaccinated, like an infant or a person with a weakened immune system. But what you see on the right is what happens when enough people in a community are immune. Even if someone does become infected, the virus or the bacteria has no place to go. And so that chain of transmission is broken. And that's really what we mean by herd immunity. When an individual has protection, when multiple people have protection, when a community has protection, then we have societal protection. And so diseases like measles are a really great example of that. It's so contagious that we need to have about 95% of a community to be vaccinated in order to maintain that herd immunity. And when rates fall below that amount, then outbreaks start to occur. And sadly, we've seen vaccine rates go down across the United States. And subsequently, we've seen measles outbreaks increase across the United States. So the takeaway is that the vaccine is not just protecting you, but it's also protecting your community. And every vaccination is going to help shield the most vulnerable among us, whether that's someone young or someone old, or someone with a weakened immune system. So now that we've talked a bit about how vaccines protect both individuals and communities, let's take a look at how we actually get there, from early research to real-world use. It requires decades of research, large-scale clinical trials, and billions of dollars in order to bring a vaccine to market. Oops, sorry, I hit that too soon. In order to bring a vaccine to market. The total development costs can be significant, but despite the high development costs, vaccines really make up a small share of what our industry does overall. Because many people know our industry is developing medicines for cancer, or they're developing diabetes medicines to treat all sorts of other diseases as well. Vaccine development creates and requires a lot of collaboration. So success is going to depend on partnerships with industry, with government, with academia, with research institutions. There's really complex manufacturing that goes into this, and infrastructure requirements to bring a vaccine from concept to production. And manufacturing really can add another layer of complexity. So the bottom line here is that bringing a vaccine to patients really relies on substantial investment, a lot of technical capability, and then collaboration. And yet the return might be comparatively modest. And the true value of vaccines really is measured in the lives saved and the diseases that they prevent. When it comes to bringing a vaccine to patients, a vaccine goes through clinical trials, then the Food and Drug Administration approves it, and what happens next is really unique for vaccines. It goes to an advisory committee at the Center for Disease Control called the ACIP. That stands for the Advisory Committee on Immunization Practices. This is typically an expert committee that guides CDC on how vaccines should best be used in practice, how they're going to be rolled out in pharmacies and in doctors' offices. So many on the line might not get too overwhelmingly excited about a government advisory committee, but when it comes to this group, it has been very influential in determining those access and coverage pieces that really create or remove a lot of friction in the healthcare system. Traditionally, ACIP recommendations have been driven by rigorous scientific review focused on safety, effectiveness, and public health need. It's a committee that has about 19 voting members. They typically are experts in immunology, epidemiology, and pediatrics. And then there are non-voting representatives from federal agencies, medical societies, industry. I happen to be the industry rep to that committee, and then other stakeholders. And the point of having these non-voting members is to provide that practical perspective. What does this mean on the ground floor? How is a patient like yourself going to actually access that vaccine, either when you go to the pharmacy, when you go to the ER, or when you go to the doctor's office? ACIP votes on vaccine recommendations, and once they're adopted, these guide the nationwide immunization schedule. So you might see that complex calendar, you might see it in the doctor's office or hear about what's recommended. And this vaccine committee plays a really critical role in designing that calendar. And yet, you might be reading in the news growing concern about politicization of that committee, or changes in that committee that might create friction within the ecosystem. The bottom line is that ACIP has been and should remain a body that's really guided primarily by science and public health. And that's really, I think, a goal that we should all share. ACIP recommendations don't just guide clinical practice, but they also trigger insurance requirements across multiple markets. And I think that this community is likely very interested in the ones that you see on the left with respect to Medicare Part B and Medicare Part D. So you can see that ACIP recommendations really do inform coverage in Medicare Part D. When ACIP recommends a vaccine, most major payers, meaning the insurance companies, have to cover it without cost sharing. So you go to the pharmacy, you get the vaccine, and you don't pay anything out of pocket. Under Medicare Part B, as in boy, certain vaccines like the flu vaccine, the pneumococcal vaccine, which is sometimes referred to as the pneumonia shot, the COVID-19 vaccine, hepatitis V vaccine, those are all covered under Medicare Part B, as in boy, again, with no cost sharing. So you go to your doctor, you get those vaccines, you do not pay anything out of pocket. Under Medicare Part D, all commercially available vaccines are covered, and recent changes to the law under the Inflation Reduction Act require that once ACIP recommends a vaccine for an adult or a senior, then that also needs to be covered without any cost sharing. So the difference between B, as in boy, and D, as in dog, B is what happens in the doctor's office typically, and then D is what happens at the pharmacy counter typically. So I know those are really important distinctions for you all, and you're probably really well aware. But the reason that ACIP recommendations are really important is because once they're signed off on, then they are typically covered and you don't have to pay out of pocket when you go to that pharmacy counter. So bottom line, these ACIP recommendations are a critical policy lever. They're not just about scientific guidance. That's a key component to it also, but there's a big policy component to what is decided at that committee because they determine who can get access to vaccines at no cost sharing across the healthcare system. So it's really foundational to public health access. One common question that we're getting a lot these days is why people, kids in particular, are receiving more vaccines now than they did growing up. And I don't want to presume, but I'm looking at the screen here and I'm guessing that folks on the line probably got fewer vaccines than kids do today. And the short answer for why that is the case is because science is really advanced. We've developed new vaccines that prevent serious illnesses that used to be common and often or sometimes even deadly. That's diseases like rotavirus, hepatitis B, chickenpox, HPV, which can cause cancer and even death. I'm sorry, and these diseases can cause even death. And as we've learned more about how vaccines can be developed safely and effectively to prevent disease, more vaccines have been added to the childhood vaccine schedule in order to give them that protection. So while the number of vaccines has increased, it reflects progress and our ability to prevent more disease and keep kids healthier. So the bottom line for me is that more shots today means fewer sick kids in the emergency room, fewer hospitalizations, and more lives saved. If my sound works, I'm going to just play this because I think it's a really helpful snippet as to why kids are getting more vaccines today than you might be otherwise familiar with. So I'm going to go ahead and play it. I think it tells a really nice explanation or gives a really nice explanation.
Why are there so many more vaccines today than when your grandparents were kids? Let's talk about vaccine schedules over time and clear this up. Now, the American Academy of Pediatrics has been a leader in crafting childhood vaccine schedules since the late 1930s. Back then, kids only got a few shots, like for smallpox, diphtheria, and whooping cough. But they also used to get infected with polio, measles, mumps, and other diseases. Not great. Fast forward to the 1960s, and we got vaccines for measles, rubella, and polio. And then in 1964, the government was like, we need to get organized. So they looked to the AAP and other experts and formed ACIP, the committee that recommended vaccines based on science, safety, and cost effectiveness. Then in the 1990s, we had even more research and real world experience, and the first full childhood vaccine schedule came out. And it was continuously updated with new licensed vaccines and recommendations. Today, from birth to 18, kids can get up to 15 vaccines. And that's a good thing because that's 15 serious illnesses that kids today are protected against that they weren't in the past. I have mentors who used to see babies die from Haemophilus influenza B. I've never seen a case. Have you seen a case of diphtheria or smallpox? That's what I thought, me neither. But we understand that you might have questions and we welcome them. Bring all your concerns, questions, and doubts to your pediatrician, a trusted healthcare professional. The internet is full of misinformation and people trying to sell you stuff. We're here to help. So stay curious and do it for the kids.
Was everybody able to hear that? Good. All right. That is actually probably the biggest win for the day is getting sound to work on a Zoom. So that's exciting.
Why are there
You might be asking questions about safety because that often comes up when it comes to vaccines. And the honest truth is that we have a really significant layered coordinated system to detect and evaluate potential safety issues with vaccines. No single system works alone. Instead, what we have is multiple data sources that come together and they complement each other. We have, first of all, a passive surveillance and monitoring system. Those are things like VAERS, vSafe, and manufacturer adverse event reporting systems. Those are sort of jargony terms, but when I say passive surveillance systems, what I mean is they collect information from people and from doctors. So if somebody gets a vaccine and they pass out in my office, I can put it, or in the ER, I can put that into one of these systems and then it'll be investigated. That doesn't mean those two things are related, but it creates a signal that then can be further investigated. So that's what we mean by passive surveillance. Somebody is putting in that information for someone else to study. That's where the active surveillance and monitoring comes into play. And there are a variety of databases that do that. But what the difference between passive and active means is that those active systems are actively looking to answer specific questions. So if I put in someone passed out when they received a vaccine, and a lot of doctors put that in, then the active surveillance systems will say, why did that happen? Was that related to the vaccine? Can we study this to understand what is going on? Is this truly related? Or did that person in the ER see someone in the bed next to them that was having something really bad done to them and they passed out because of that? Because sometimes in medicine, there are these confounding things that happen at the same time. And if you just look at it in isolation, you might be led down the wrong pathway. So that's the difference between passive reporting systems and active reporting systems. Passive take a lot of information in. Active look at that information and then they study it to figure out, is there actually a true association here? And then finally, there are these research and evaluation systems. There are programs all throughout the country. There are post-marketing requirements. Again, sort of more active research programs. So again, passive systems, they help take information in to try to detect early signals. Active systems help validate or refute those associations. And then research networks investigate potential risks in more depth. So the bottom line is that vaccine safety is continuously monitored. There's multiple tools and data streams, and they all work together to help ensure that any potential safety concerns are detected quickly and then evaluated thoroughly. So with that, that is a sort of run through of the state of affairs with vaccines in the US in terms of the policy and the systems that we have in place. Eileen, I'm happy to turn it back to you or take a few questions.
It doesn't look like anyone put any questions in the chat. So does anyone have any questions that you would like to ask at this point in time?
I have one, Eileen. This
Okay,
is
go ahead.
Barbara. I just wanted to know, I'm hearing the seniors saying they're going in for their vaccinations and they're getting 3 at a time. And some of them are becoming very ill. So if that's common now to give them all 3 at the same time, I think it's RSV, COVID, and pneumonia.
Dr. Ybarra, do you have any reactions to that?
Yeah, you should always talk to your doctor or your pharmacist about whether or not you should what we call co-administer vaccines at the same time. So I think that's a good question to ask because it's really going to depend on the specific vaccines that you might want to get in that day and your individual health circumstances. So you in a year do need an annual, I believe over 65, you're recommended to get your annual flu vaccine, of course, and then the COVID vaccine booster. And so it's worth talking to your doctor about how to get both of those in a way that's both convenient for you and then is best for your individual health circumstances.
And my suggestion, having just recently had a 2-year-old that I have custody of, and about 6 months ago, they gave him 6 one day. And I told that pediatrician that was never happening again. And she looked at me like I had lost my left eye. And I said, look, you didn't have to go home and take care of that baby. I did. And she said, well, then you have to come back next week. I said, that's a lot easier than dealing with a baby that was terribly, terribly, terribly uncomfortable that I spent 24 hours doing nothing but holding. And what I have known for many years is that part of the stacking is what I would call it, is that people are sometimes reluctant to come back more than once. And so the medical community, I think, tries, and there's nothing wrong with it, to do multiple vaccines on one day to reduce the return visits. But I think, if people are motivated to get the vaccines, they're going to come, and they probably don't, may or may not see the benefit of doing multiple ones on multiple days. So I would suggest that anybody who's had an experience where they had multiple vaccines one day and became ill, that they next year space those out every 2 or 3 weeks over a period of time so that they, can avoid that.
I would say this is a really important and timely topic, and I understand why people might feel like it's a lot. And I think that's a very normal question to have. One thing, though, to keep in mind, particularly with babies, is that vaccines actually have a relatively low amount of what we call antigens, so what you're being exposed to. In particular, compared to the environment that they're in, babies are exposed to thousands of antigens on a daily basis. And so vaccines oftentimes are much less than what they're getting exposed to through their environment. So it's a really important conversation to have with a doctor for a person that might be recommended to get multiple vaccines in one setting, or with a pediatrician that's recommended to get vaccines to stay up to date on their schedule. So I think our goal is really aligned in wanting to keep people healthy. And so we need to do that in the best way possible.
So does that answer your question, Barbara? Okay, there's a couple questions that have been put in the chat. One is, since COVID and flu shots don't prevent disease, do they actually create herd immunity? Dr. Ybarra?
Yeah, that's a great question. When we talk about herd immunity, we typically think about those vaccines in the top right of that slide that I showed. And I can pull it, well, maybe I can pull it up. I'll try to find it and pull it back up. But basically, when you think about the herd immunity, it's for those vaccines that create that sterilizing immunity, like measles, like polio, and needing to maintain high vaccination rates. So those are really more for the vaccines that prevent transmission of disease versus the vaccines that protect against severe disease like COVID and flu. And so it's a different sort of goal with that vaccination. Now, there's a lot of confusion there because I think before we knew a lot about the COVID virus, our hope was that vaccination could create herd immunity for COVID. But we found over time that COVID behaves a lot more like flu and that it mutates quite significantly. And that's why you hear about all of these variants. You heard about the Alpha variant and the Beta variant, the Delta variant, and the Gamma, and now we have the Omicron variant. And so vaccines that target viruses that change significantly, like COVID and flu, oftentimes are very hard for you to reach herd immunity, or it might be impossible, at least in our current circumstances. Whereas a virus like measles or polio that doesn't mutate very much, it has to do with the type of genetic material that it's made from. Those viruses don't change very much. They don't mutate rapidly, so it's easier to maintain or achieve herd immunity when you have enough people vaccinated. I realize that's a lot of biology, so hopefully that made sense. I'm happy to sort of pause there and see if folks have any follow-up questions, which would be completely understandable if you didn't major in biology or go to medical school.
Gregory, did that answer your question, or do you want to pursue that some more? Okay. The next question in the chat is, do states have different systems? Do states have different systems for keeping track of individual vaccine records?
Yeah, I'm not aware of that. I think that probably the best thing to do if you want to know about your vaccine status is talk to your physician, and see if they have sort of more of an up-to-date vaccine record. I'm not familiar with sort of state level systems that track that.
Actually, Colorado does have a tracking system. And actually, somebody asked me the other day, because apparently they have received vaccines at multiple locations. And I know there's a state system, so I did agree the other day to track that down with the Colorado Department of Public Health. So I can make a note, Kurt, and send you an email as soon as I get that figured out as well. But yes, Colorado does have a system that we track. And then the next question he asks is, what is the best place to see if you are up to date with your vaccinations? Again, I guess that would be the best option that I would know about if you have used multiple providers. Because otherwise you'd have to go back to those individual providers. And like I say, I know that there's a state reporting system. What I do also know about the state reporting system is that there is like a 2-week requirement for pharmacies and or doctors' offices to upload those. So it's not like a real-time report that you would get, but it should be fairly current.
That's great intel. Thank you.
Eileen, do you want a little more information on that? I might be able to help.
Oh, sure. If you know the answer, go ahead.
I don't know if I know it fully, but just in my experience in vaccines at the legislature. So Colorado has a requirement, at least for anybody in school, ages, early childcare. So I guess like 3 months through university, that you must track your vaccines. So it is the Department of Public Health that has that. They release information to the schools every year, saying this is the percentage of folks we have vaccinated. It gets a little tricky when you're looking for individuals. Although those things are uploaded, it's more sort of a general system of like, we've had this many people in Colorado vaccinated for measles in X year, and then they kind of do track that. I think though that providers do have access to a back-end database within the Department of Public Health and Environment that can help them figure out if an individual is vaccinated for something. So if somebody is confused, that information, like you said, is uploaded at the Department of Public Health and Environment, but oftentimes it's the provider that needs to find it, based on my knowledge of the legislation we passed here in terms of tracking vaccines. So
that may be very true, because a couple years I did a project with Walgreens, and people said, well, what if I don't know what I have or didn't have or whatever? And the lady that I was coordinating with said, well, we can help you figure that out. So it may be that it's provider driven as opposed to individual driven. And as to follow-up question, Kurt, in our situation, we moved from Iowa to Colorado, and it is difficult to track. Yeah, I have no sense about how to help you there, unless you can get some sense of it from your former primary care physician. Okay, any other questions? Okay. Well, thank you very much for joining us today. We have one more session next week on this Wednesday Lunch and Learn, and it will be on helping to understand the Medicare Savings Program and the extra help with the Medicare Savings Program being that part of that helps to pay for your Medicare Part B premiums. And if you're really low income, it can help with some of the deductibles and the copays, and the extra help helps to pay for the Medicare Part D deductibles and copays. So that will be the conversation next week. Thank you all for joining us. There are still a couple more Medicare Mondays that will be in person on November 10th and 17th. Check the website. And then on December the 1st, I'll do one more session on what are the changes for 2026 for Medicare. And then I'll also, if you know anybody who is new to Medicare, we'll be doing a new to Medicare session as well on December 1st. And both of those will be on Zoom. So check the website if you're looking for additional opportunities and information about Medicare. Thank you all for joining us, and a special thank you to Dr. Ybarra and to Erin for helping to make this possible.
Thanks, Eileen. Thanks, Aaron. Bye, everybody.
Bye.